So a complete review of neurology would not be totally complete without talking about the tumors of the nervous system. We're going to talk about a lot of them, 7 to be exact. So the first class of tumors, sort of a rough class of tumors, are those pertaining to what's called gliomas. Gliomas come from glial cells. Glial cells are the cells that are within the brain parenchyma. So of glial cells, we have astrocytes. The tumors that come from that are called astrocytomas. So there's the low-grade astrocytoma and Oligoblastoma multiforme. Now, we have 4 grades of astrocytomas, 1, 2, 3, and 4. They're determined histologically, so not something that you're going to need to know how to do. We only talk about 1, 2, and 4 because 1 and 2 are considered the low-grade astrocytoma, and 3 tends to progress into 4. So those are really the only tumors that are important to know about as far as astrocytomas. We also have oligodendrocytes. Oligodendrocytes are responsible for myelinating nerves in the central nervous system, and so those tumors are called oligodendrogliomas. And then finally, the lining cells of the ventricles are called they're called ependymal cells, but the tumor is called ependymoma. So those are 4 different tumors that are part of the tumors referred to as gliomas. More specifically, it's the astrocytomas that you hear referred to as glioma, but these are all tumors of glial cells. Okay, now the tumor that's from the epithelial cells of the meninges is called a meningioma, and then a tumor that comes from some of the primitive cells in the medulla is a medulloblastoma, blast meaning primitive cell, medulloblastoma. And then finally, tumors coming from the Schwann cells, which is the myelinating cells of the PNS, is a Schwannoma. And we'll also talk about metastasis to the CNS and some less common tumors. So approximately 18,000 patients in the U.S. are diagnosed with a primary brain tumor. These are all, what we're talking about, are primary brain tumors. They're not metastases. These are tumors that arise from nervous system tissue, either in the brain or in the spinal cord or on a cranial nerve. In children, primary brain tumors are the most common solid tumor, and they are the second leading overall cause of cancer death, and that would be second only to a non-solid tumor being leukemia. In adults, primary brain tumors are a little bit less common, relatively speaking, but they are actually the 7th leading cause of cancer death, and these tend to shift around from year to year. But the most common cause of cancer death is always lung cancer, and then colon is number 2, breast is number 3, pancreas, prostate, and leukemia are 4, 5, and 6. So this is just the estimated cancer deaths in the U.S. in 2013 from the American Cancer Society. So brain and nervous system cancers are down there, number 7. So even though this isn't a common diagnosis, it is a very common cause of cancer death. So what that means is that when you get a brain or nervous system cancer, it tends to be quite aggressive. Primary brain tumors are more common in men, and the only exception for that is meningiomas, which do occur in women more at about a 3-to-2 ratio, but overall, men get brain tumors more than women. Metastatic brain tumors, meaning a tumor from a different focus, such as breast, bone, skin, etc., are far more common than primary brain tumors. So if you see a tumor in the brain, it's more than likely a metastasis from a secondary site. But what we're going to talk about here are primary brain tumors, meaning tumors that arise from the brain or nervous system tissue itself. Some of the risk factors for brain cancer from nervous system tumors are genetic syndromes, and that could include neurofibromatosis, that could include Li-Fraumeni syndrome, which is a p53 mutation, and also exposure to ionizing radiation is another risk factor. And age tends to be a risk factor for many of the tumors as well. There are a lot of cancers that strike in very young and then also in the more advanced ages. So where do the tumors happen in the nervous system? The way we define it is either supratentorial or infratentorial. And when we say tentorial, what we mean is the tentorium cerebelli. So what the tentorium cerebelli is it's a lining that separates the cerebellum from the cerebrum. So if it's infratentorial, it's below that tentorium cerebelli. If it's supratentorial, it's above the tentorium cerebelli, pretty much meaning in the cerebrum. Now in adults, 70% of primary brain tumors are going to be supratentorial, so they're going to be in the cerebrum. And 30% are infratentorial, so they'll be in the cerebellum, in the brainstem, or in the spine. Children, it's the opposite. 70% are infratentorial and 30% are supratentorial. Now, overall, in children, brain tumors tend to be more posterior. So if they do affect the cerebrum, they're more likely to affect the parietal or occipital lobes as opposed to the frontal lobes. And they also tend to be more caudal. So they are lower down, more towards the brainstem as opposed to further up towards the cerebrum. So they're more likely to be posterior and down. What are the symptoms of brain tumors? Now, there's various different kinds of symptoms that you can have depending on where the tumor is, depending on what kind of tumor it is, but the stereotypical symptoms that come with most brain tumors are headaches, which tend to be worse on awakening, seizures, and altered mental status, which tends to be more subtle, such as personality change and apathy, maybe even fatigue. And then there can also be focal neurologic deficits depending on where the tumor is. The other symptoms are going to depend on the location. The symptoms of tumors, of brain tumors, are progressive and persistent. Now they're persistent because the tumor doesn't go away. It's not like it's shrinking for a little while and then growing. It's constantly there, so the symptoms are going to be persistent. The symptoms are also progressive because the tumor tends to get bigger over time. Now, how quickly it gets bigger is going to determine how quickly progressive the symptoms are. Some tumors grow very slowly, like craniopharyngiomas, and some tumors grow quite quickly. Okay, so this is just the tumors of the nervous system. Again, we already saw this slide. Now in children, the number one type of primary brain tumor is a low-grade astrocytoma, and number 2 is an ependymoma, and number 3 is a medulloblastoma. So that medulloblastoma is, remember, infratentorial because it's in the brainstem, in the medulla. With adults, the number one cause of primary brain tumor is glioblastoma multiforme, which is the high-grade astrocytoma, and then meningioma and low-grade astrocytoma. So let's talk about what these are in more detail. We're going to talk about gliomas, what are referred to as gliomas, and that includes the cells that are of the brain parenchyma. So that's astrocytes, oligodendrocytes, and the lining cells of the ventricles. So gliomas or astrocytomas tend to be referred to as gliomas, even though glioma kind of represents this whole class. You may hear glioma and astrocytoma referred to synonymously. I like to use the word astrocytoma because it's more particular. So some reference of nomenclature: there are 4 histologic grades of astrocytomas, 1, 2, 3, and 4. They're determined histologically. And grade 1 is otherwise referred to as a juvenile or pilocytic astrocytoma. That tends to happen more in younger children, and it also tends to be more in the brainstem or in the cerebellum particularly. Grade 2 astrocytoma is often generally just referred to as the low-grade astrocytoma. It tends to be in younger adults. Grade 3 is called the anaplastic astrocytoma, and this tends to progress quite quickly into glioblastoma multiforme, which is grade 4. Now, grade 1 astrocytoma is, once it's resected, there's a pretty decent cure rate, whereas grade 4, the survival is quite dismal. So there's a big difference between these grades. In these tumors, as I mentioned, you may hear glioma referred to as astrocytoma or vice versa, so don't be shocked if you hear that from different sources. Gliomas, though, refer to any of the tumors that are of the parenchyma. Astrocytomas, which we're talking about here, are particularly from the astrocytes. So the cell of origin for astrocytomas are the astrocytes, and astrocytomas are the most common tumors both in children and in adults. The only difference is in children, the most common tumor is the grade 1 astrocytoma, which is the curable pilocytic glioma, and in adults, it's the deadly glioblastoma multiforme. So the low-grade astrocytoma, what would we expect in the history of the patient? Well, the patient is going to be younger. They tend to be younger. Risk factors, of course, are what we described as risk factors for any brain tumor. So exposure to ionizing radiation, a family history of brain tumors, and known cancer syndromes. What are the symptoms? Well, they're the typical symptoms that you would see in any brain tumor. So seizure, new onset seizures, headache on awakening, and then altered mental status. So remember that any new seizure should be getting a CT. And on CT, we would easily see a tumor. Headache on awakening is also very, very, very suspicious for brain tumors. If you get headache during the day, that's one thing, but if your headache is severely worse when you wake up, or you wake up from a headache, that's a red flag towards a tumor. So whenever you're talking to a patient with headache, you should be asking them when it's worse or if it wakes them up at night. And then altered mental status, that could include apathy, sluggishness, personality changes, memory loss, and so forth. As mentioned, in children, there is a posterior and cerebellar predilection for tumors overall. So that also goes for low-grade astrocytoma. So in children, you're more likely to see your astrocytomas in the posterior part of the brain, in the occipital lobe, or in the cerebellum. So that may change what the symptoms are. In children, you may see more symptoms such as neck pain, ocular symptoms. Particularly if it's in that occipital lobe, you may see a homonymous hemianopsia with macular sparing. You may see some dizziness or ataxia if it's in the cerebellum. For diagnosis, any of these symptoms, like seizure, headache on awakening, altered mental status, all of those are going to warrant imaging. So if a patient presents with any of these, but particularly the seizure, they're going to need to be imaged. And the best initial test is going to be CT. It's not the most accurate test. It's not the best imaging test, but it's the best test to start with because it's cheaper and because it can rule out a tumor if it's normal in most cases. So you should always start with the CT. If you see a tumor, then go for the MRI because it will give you a better idea of where the tumor is at. But the CT is good enough to get an idea if there's an astrocytoma present. The most accurate test, of course, with any cancer is going to be biopsy, and that's going to be required for formal diagnosis because we need a biopsy to grade the cancer. These are histologic grades. So here is some astrocytomas. These are grade 1 astrocytomas, and these are both in a child. You could probably guess based on the shape of the head relative to the length of the neck. But you can see here, both of these tumors are in kind of the same spot. They're both in the cerebellum. So both of these are left cerebellar tumors. And this one kind of crosses the midline a little bit. But remember, in children, you're more likely to see astrocytomas be in the posterior part of the cerebrum or in the cerebellum. Okay. And then here we've got, this would be sort of more in the parietal lobe. And here's another one. This is more in the parietal occipital transition area. And these are grade 2 astrocytomas. But don't worry about figuring out how to grade them just based on how they look. You can't do that because remember that these are histologic grades. What you can, though, infer usually is that in very young patients, younger patients like children, they're going to tend to have grade 1 astrocytomas, whereas in older young adults, they're going to be more likely to have the grade 2 astrocytomas. So what do we do for treatment? If it's a grade 1 astrocytoma, we can do surgical resection, and a lot of time that's going to be curative. And we continue to observe them with serial imaging. With the grade 2 astrocytoma, we're also going to resect their tumor. However, that tends to not be curative, and so we go on with chemotherapy and radiation. As far as prognosis, grade 1 can be cured with resection. For grade 2, it tends to have a pretty good survival. The median survival is around 7 years. Okay, now let's talk about glioblastoma multiforme. This is grade 4. This is a much different story. So this is going to be much more common in older adults. Remember, this is the most common primary brain tumor in adults. Risk factors are going to be the exact same here. So ionizing radiation exposure, family history, or known cancer syndromes. Symptoms are also going to be the same. Headache on awakening, seizures, altered mental status. You may see focal neurologic deficits depending on where the tumor is. And the symptoms don't remit and they're progressive. They will progressively get worse. Remember, with seizures, headache on awakening, altered mental status, if you're thinking brain cancer, you need to get imaging if that's on your differential. So the best initial test is going to be CT, and an MRI is always going to be more accurate if you have suspicious CT findings. However, you're going to need to get a biopsy for formal diagnosis. How do we treat glioblastoma multiforme? Well, it's usually going to be a lost cause. Most of these patients will die. However, we do try. So we start with debulking, where we take most of the tumor out. That's resection. And then we do radiation and chemotherapy. We tend to use temozolomide and carnoustie. Carnoustie is an agent that helps the absorption of temozolomide in the brain parenchyma. And the prognosis is dismal. So with glioblastoma multiforme, you usually know it's going to be a glioblastoma multiforme because it's in an older adult, usually in their 50s or 60s. A lot of times these will be bigger tumors. They may be more towards the front of the head. You may see some necrosis in the middle, some calcification, but none of these things necessarily imply that it's a glioblastoma. But it's very unusual to see a glioblastoma in a young person. Much more common to see it in an adult or older adult. So here's a couple glioblastomas here on the right and on the left. And then this is a pattern you commonly see in glioblastomas. If they cross the midline, it's called a butterfly pattern. So you see how you kind of have a narrowing where it crosses the corpus callosum here, and then you've got sort of two focuses of tumor. And then here's another one right at about, looks like, I'm not sure, this doesn't look like brainstem. Looks like it's about, it looks like it's parietal lobe, occipital lobe. All right. Okay, so oligodendroglioma. So now we're talking about a different origin cell. Up until now, we've been talking about cancers that originate from astrocytes. Now we're talking about a cancer that originates from an oligodendrocyte. So this is seen primarily in adults, not in pediatrics. It is less common, and usually oligodendrogliomas show up in the frontal lobe. So the median age for oligodendroglioma is 35 years. Of course, any of the ionizing radiation, cancer syndromes, they can all increase your risk for oligodendroglioma. Symptoms are going to be quite the same as well. So seizure is reported in the vast majority of patients, as well as headache. And there also may be increased intracranial pressure. When you do your physical exam, you may see papilledema. The patient also may report a headache from that, so more of a chronic headache as opposed to a headache on awakening, and they may have some gait issues. For diagnosis, again, if it's a seizure patient, you're always going to be doing a CT. So that's the best initial test, MRI if you see a tumor, and then the most accurate test is a biopsy. The treatment for oligodendroglioma, like most tumors, is going to be surgical resection and then radiation, and this, of course, also being a cancer, is going to need chemotherapy. So we use the PCV therapy. PCV chemotherapy is procarbazine, Sinu, which is also known as lomustine, and vincristine. So procarbazine, lomustine, and vincristine. Sinu is the, I think that might be a trade name for it. That's what it's generally referred to in the wards, but it's called lomustine as far as the generic name. The prognosis for oligodendroglioma is much better than glioblastoma multiforme. It's pretty decent, but the problem is it tends to recur, and when it does recur, it's usually a lot less responsive to chemo and radiation. So here's an oligodendroglioma. You really can't tell much of a difference between this and the glioblastoma. Other than that, there's, on these ones at least, there's not quite as much central necrosis. It also tends to be more frontal. I'm not sure exactly where this is. It looks like it's sort of parietal lobe. And then this one is also more frontal. So don't worry, again, don't worry about being able to tell what the tumor is based on CT, because you are going to need to get a biopsy to tell what kind of tumor it is. But what you should know is oligodendrogliomas tend to be more frontal, and they have a better prognosis than glioblastoma. Okay, ependymoma is our third type of glioma, and the origin here is the ependymal cells, and the ependymal cells are cells that line the ventricles. So these tumors are going to be, they're going to appear to be inside the ventricles because they're coming off of cells inside the ventricles. So this is the second most common primary brain tumor in children, and it's very common in children under 3. And it also is pretty common in adults. I think it's like number 4 or number 5. So this is common in both children and adults of all ages. This is also a very common cause of spinal cancer. So when you think about spinal compression, this can be a major cause of spinal compression, extramedullary spinal compression. Neurofibromatosis type 1 has a particular correlation with ependymoma, so that's something to think about. But certainly you don't need to have that to get an ependymoma. In children, the most common symptom is going to be an obstructive hydrocephalus, and that's simply because this is a tumor that comes out of the ventricles. If the tumor blocks the ventricles, then you're going to have an obstructive hydrocephalus. And what happens then is you continue to create cerebrospinal fluid. That's going to elevate your intracranial pressure, and so that's going to cause papilledema, headache, and cerebellar dysfunction, as it would in any case where you have elevated intracranial pressure. In adults, this tends to be more of a cause of spinal cancer. We see this in spinal cancer in adults more often. So a lot of times, if this happens in adults, you may see symptoms of cauda equina syndrome. But certainly not all the time. You may see elevated intracranial pressure in adults as well. For diagnosis, of course, always imaging is going to be important. Since the person has hydrocephalus, you're going to need to get imaging. That's always going to be an indication for imaging. And if a patient has cauda equina syndrome symptoms, such as loss of sphincter tone or loss of sensation on the saddle or on the leg, or pain on the legs, then you're going to also need to get imaging there too. And so in this case, then you get a CT or an MRI. Probably start with the CT though, and then work your way up with an MRI if you see a suspicious mass. So that would be the best initial test. However, the most accurate, again, is going to be biopsy. You can see how the diagnostic workup is quite the same with any suspected primary neurologic tumor. The treatment for an ependymoma is going to be surgical resection and then radiation and chemotherapy. The prognosis is decent, but the recurrence rate is high. Now, when you look at a CT, an ependymoma is a little bit more conspicuous. So here's an ependymoma here. These are both in the lateral ventricles. And you can see that this is an ependymoma because it is extending into the ventricles. If you had a glioblastoma, it would be more in the the white matter of the brain, whereas this is extending into the ventricles. And not only is it extending into the ventricles, but you also have enlarged ventricles, which shows that there's some level of increased intracranial pressure, obstructive hydrocephalus. So this is an ependymoma. Here's another ependymoma. This is an ependymoma at the fourth ventricle. So you can see coming down here at the brainstem, it's obstructing here, and I believe this is the same patient where you have this obstruction here. Now you've got enlarged ventricles, and so this is going to cause the hydrocephalus. Okay, meningioma. So a meningioma originates from the meningothelial cells of the dura mater, and this is primarily in adults. Meningiomas are always benign, and usually they are cranial, so they're in the brain area. They may be spinal, but they tend to be cranial. Patients with a history of neurofibromatosis type 1 are at increased risk for meningioma, and remember that meningioma is the one primary brain tumor that is more common in women at about a 3-to-2 ratio. The symptoms are going to be the stereotypic symptoms of seizure and morning headache. Impingement on local structures can cause weakness and apathy, depending on where it is. For diagnosis, again, if a patient comes in with seizures, they've got morning headaches, you should always be thinking brain mass. And so the initial test is going to be a CT, followed by an MRI, and then getting a biopsy for diagnosis. And with meningiomas, because it originates from the dura mater and extends into the cranial cavity, usually you can find this dural tail, which is the connection between where it originates, which is on the dura mater, and then the tumor, which is pushing into the cerebral cavity. And so that's called a dural tail. I'll show you what that looks like. The treatment here is surgical resection. This is a benign tumor, so it's not going to require radiation or chemotherapy. And the prognosis is really good, but like any primary brain tumor, unfortunately recurrences are common. But with this tumor, it's not malignant, so it's just going to mean operating again. Unfortunately, that's obviously never a good thing, but this is a benign tumor, so that is a good thing there. Okay, so here's a meningioma, and another thing that I neglected to tell you is that a meningioma can also extend into the epithelial tissue, and we actually see that going on right here. So you've got some cells kind of going into the deeper endothelium, and so that's what this little welt is here. I should have probably gotten a picture to show you what that looks like on the outside. But anyhow, here's your little dural tail. It's kind of hard to see here. But you can see that here's our dura mater right here, and then this is your dural tail, and then this is the tumor itself. And this tumor is not part of the brain parenchyma, it's part of the dura mater, and it's pushing the tumor in. This is a better one right here. You don't really see the dural tail here because it's a lot bigger, and it's not quite as mushroom-shaped, so to say, but it's a lot bigger, and you can see that this is pushing brain parenchyma. It's not part of brain parenchyma, it's extending from the dura mater, which you can see dura mater coming up here, and then going all the way around here as the tumor, and then continuing here, and it's pushing the brain in, it's compressing the brain, and you can see that there's a midline shift. So these midline structures are not where they should be. They're shifted over, in this case, to the right side, because you have a left meningioma, pushing the left brain in. Here's another one. Actually, this is the same picture. Sorry about that. This is another one here. So this one is a little bit more subtle, but you do see that dural tail here. And that dural tail is what really tells you that this is a meningioma. But again, you do need to get a biopsy to make the formal diagnosis. Okay, Medulloblastoma. So Medulloblastomas, the origin is really unknown. This is under the category of PNET, primitive neuroectodermal tumors. Likely the medulloblastoma arises from embryonal cells in the medulla. What we do know, though, is that it happens in the medulla. It can also happen in the cerebellum, too. Virtually always the medulloblastoma will be in children. Medulloblastoma is the #3 most common cause of primary brain tumor in children. What is the history in a patient with medulloblastoma? Well, like any tumor, they could have no history, but there is an increased risk of medulloblastoma in patients with the p53 deletion in what's known as Li-Fraumeni syndrome, which is a familial syndrome. It's inherited. Symptoms, because this is in the medulla, it tends to block the fourth ventricle because the fourth ventricle runs right through the medulla. And so what you can get is an obstructive hydrocephalus, and that's quite common, which can produce headache and vomiting due to elevated intracranial pressure. And also because this is present in the medulla or cerebellum, remember the cerebellum is responsible for gait, and so gait issues and stumbling are common. You can also get visual changes if it's affecting any of the cranial nerve roots. So you can get visual changes such as diplopia because of effect on perhaps cranial nerve 6, which is the abducens nerve. As far as diagnosis, again, if you have a patient with hydrocephalus, headache and vomiting, if you have a patient with gait issues, you're always going to be doing imaging. And the best initial imaging is CT, just simply because it's a little bit cheaper. If you see something suspicious on CT, then you can go ahead and get MRI. Please just remember that MRI is more accurate than CT, but that doesn't mean we go straight to MRI. We like to have abnormal results on CT before we go and do an MRI, because an MRI it takes a long time and it's expensive, and so we like to do a CT first. It's faster, and we tend to see tumors very easily on CT. And then we can go get an MRI if there's something suspicious that we need to investigate further. And of course, always the most accurate test and required for formal diagnosis is biopsy. You've heard me say this probably 6 times now. Treatment for medulloblastoma is going to be surgical resection, and because this is a malignant tumor, it's radiation and chemotherapy after that resection. Prognosis is going to be worse if the patient is younger, particularly under age 3, and that tends to be because we don't like to use radiation and chemotherapy in patients that are that young. We can if we need to, but the prognosis is slightly worse with younger age, and it's also worse, of course, with any cancer if there's metastatic disease. So here's a medulloblastoma, and what kind of makes this a little bit easier to diagnose is that it's in the medulla. These are, if you can't tell, these are both, well, this at least is a child. You can just tell based on the size of the head relative to the nose and those little tiny vertebra. But this is in the medulla. Of course, we are going to need usually it's going to be relatively obvious based on the clinical symptoms and the age and everything, but we do technically need a biopsy for diagnosis. Here's some other ones in the medulla. You can look here. This is actually the same patient, pre-resection and post-resection. So here's the medulloblastoma right here, and you can see that this is blocking the 4th ventricle, causing a hydrocephalus. You've got expanded lateral ventricles, and now that it's resected, the 4th ventricle can communicate down, and the lateral ventricles are no longer engorged with CSF. Okay, let's talk about the schwannoma. The schwannoma is technically a tumor of the peripheral nervous system. So a schwannoma, when we think about a schwannoma, of course, it derives from Schwann cells being the myelinating cells of the peripheral nervous system. When we think of schwannomas, the most common, I don't know if it's the most common type of schwannoma, but the most common type of schwannoma that's taught and that comes up on the USMLE is the acoustic neuroma. And that happens in conjunction with neurofibromatosis 1 or 2. In neurofibromatosis 2, it is often bilateral. A bilateral acoustic neuroma is practically diagnostic of neurofibromatosis type 2. So the history of a patient with schwannoma, particularly with an acoustic neuroma, is going to be neurofibromatosis. We'll look at a couple of those pictures. But certainly you can get a schwannoma on lots of different peripheral nerves, but it just tends to be most notorious on the acoustic nerve, the vestibular, the CN8, which is the vestibulocochlear nerve. And so this can affect hearing. It can also affect balance. So everything that's carried on cranial nerve 8, both your hearing and your balance from your vestibular system, those would both be affected by an acoustic neuroma. The acoustic neuroma tends to be right about at the root of the cranial nerve, so right about at the pontomedullary junction. So you're going to lose both the vestibular part and the cochlear part of the nerve. So you'll have both sensory neural hearing loss and vestibular symptoms, which would be like loss of balance, vertigo, and so forth. Remember, the vertigo, because it's central vertigo, is going to be the up or down beating nystagmus, and it won't respond to Dix-Hallpike. Okay, diagnosis, again, best initial test is a CT, MRI is more accurate, most accurate test is a biopsy. Treatment is going to be surgical resection, prognosis is good, but as you can imagine, because there's a genetic basis to this, a schwannoma often can recur. So here is a schwannoma. This is the pontomedullary junction right here. See where it kind of indents? That's the pontomedullary junction. And it comes out right about well, it's not at the pontomedullary junction, but cranial nerve 8 comes in pretty close to there. And so here's the mass right here, and this is your acoustic neuroma, and this is unilateral. And you would know that this is an acoustic neuroma because the patient would have hearing loss on that side, and they would also have balance problems. And here's bilateral acoustic neuromas. They're not necessarily the same size, but they are bilateral. So this is a patient with, you guessed it, an F2. Here's another one. Some less common tumors include hemangioblastomas. This is associated with von Hippel-Lindau's disease, and these tend to happen at the cerebellum. So just remember the association between von Hippel-Lindau disease and hemangioblastoma. Von Hippel-Lindau disease is talked about in a different section. It involves the renal system as well. Craniopharyngioma is more common in children. This is a tumor that arises from the pituitary stalk. It can be confused with a pituitary adenoma just because it's so close. But with craniopharyngioma, we tend to have endocrine dysfunction because what you're getting is a tumor at the pituitary stalk, and that's blocking all of your hormones coming down from the pituitary. So it's going to block your pituitary hormones. You're not going to get those into your circulation. And so what you get is panhypopituitarism. Not because you're not making the hormones, but because they're stuck, because this tumor is compressing the stalk. You can also get visual disturbances. This is close to the pituitary, so it can compress upon the optic chiasm, which would cause a bitemporal hemianopsia. It can also compress on some of the upper fibers. That would cause a bitemporal inferior quadrantanopsia. But either of those, you will get visual disturbances. And then, of course, you can also get a headache, like in pretty much any brain tumor. The way we take care of this is surgical resection. They may recur. Pituitary adenoma or neoplasm, we talk about this in the endocrine section. These are benign symptoms. I should also say that craniopharyngiomas also tend to be benign. Pituitary adenomas are benign. They often involve bitemporal hemianopsia, particularly if they're macroadenomas. In men, they tend to be macroadenomas, whereas in women, they tend to be microadenomas. So bitemporal hemianopsia, remember, that's just simply because it's compressing upon the optic chiasm, so you're going to lose your left visual field on your left eye and your right visual field on your right eye. You may also see endocrine abnormalities depending on if this is an active adenoma secreting some kind of hormone. And the way we take care of this is by surgical resection. And then finally, brain metastases. That's pretty obvious what that is. These are tumors from other primary sites, most commonly lung, skin, and breast. The way we take care of this is just simply through radiation. However, the prognosis for brain metastases tends to be somewhat dismal, just simply because when a patient has a primary tumor, let's say in their lung or breast, and it's metastasized to the brain, usually that means it's metastasized to bone and other sites too. So this is a very, very, very disseminated cancer, and so the prognosis is bad just because of that. So here's a craniopharyngioma. It's kind of hard to tell if this is a craniopharyngioma, not a pituitary adenoma, but you'd be able to tell based on the symptoms. And here's metastases to the brain. So here you can see some cavitation, and then here you can see some surrounding edema around the tumor sites. So remember that metastasis to the brain is the #1 brain tumor overall, but it's secondary, not a primary brain tumor, obviously. And this is just to recap what we went over. We talked about the gliomas, which are astrocytomas, oligodendrogliomas, and ependymomas. We talked about meningiomas, medulloblastomas, and schwannomas. We talked about those less common tumors, and we talked about the most common brain tumor, the secondary brain tumor.